Thank you, sir.
Good evening, friends. Sushil, thank you so much for giving me this honor to be in front of all our August gathering. And today's CAV, as Sushil already said, is two talks we're going to have, Dr. Vanita and Dr. Vivek. So, point is that today's CAV is, I have two eminent cardiologists who has worked so hard all throughout and reached this level to give the introduction to the long list of what they have done in their life and what they have achieved in life by working hard all throughout and get to the great level. Dr. Vanita is an MBBS, MD and fellow from DNB Cardiology from Escort Hospital, and she has done a lot of work in electrophysiology and pacing. She got training from St. Luke Institute in USA and some institute in Germany also. All this credit goes to her, and she is now practicing and establishing an institute in Apollo and facility for electrophysiology and pacing. So compliment to you, ma'am, for all this. There's so many things to talk about you, but I said not too much to say right now. I would request you to take this further. And Dr. Vivek, I'll say secondly, first you will talk about. So let Dr. Vanita to give a talk right now, and then we talk about Vivek. Yes.
Thank you so much.
Gujesh, ये लाइट बंद करना। ये वाली लाइट बंद करना।
Good evening, everybody. It's such a pleasure to meet you all, and thanks a lot, Dr. Chauhan, for making it possible. I have always been troubling him that please, sir, milte hain. Let's do a CAV, because one thing I know about this physician forum is that you all are so dedicated towards academics, and we enjoy coming here and talking to you about the academics. Whatever we are doing, whatever new things are being done, it is a pleasure being here. Actually, I have not enjoyed so much in any of the forums across Delhi NCR as much as I enjoy interacting with everybody in the physician forum. It is my pleasure to be here, and I always thank Dr. Chauhan for giving us the opportunity for being here. And thank you, Dr. Mathur, for such kind words. Dr. Chauhan is right. We were working, me and Vivek both were working in Max. I am a cardiac electrophysiologist. We have a very close association with Dr. Viveka. Dr. Viveka does interventions, I do electrophysiology, and Vivek is totally trained into tower and structural heart. So we had our own domains, but we worked together as a team, and it has been a pleasure working together for 10 years. But we then made our choices in our career, and I moved to Apollo. Then Vivek decided to come and establish the structural heart program in Apollo, in the first Apollo Delhi. So we need your support and blessings and wishes to create the new departments in Indraprastha Apollo Hospital. So that is what we are looking forward from your side to come and to please be of support to us, so that we are able to do a good name in Indraprastha Apollo also, as we were doing in Max Saket. So one thing is very tricky today about our talks. I'm a device person, he's a structural heart person, and both of us are talking about medical therapy. So अगर किसी को मना करना हो ना बोलने के लिए, तो उसका बिल्कुल opposite topic दे दो, यही मेरे को हुआ है. I'm a device person, I do pacing, I deal with bradyarrhythmias, tachyarrhythmias, I deal with heart failure. मुझे क्या क्या hypertension पे बोलने के लिए, मतलब how can I tell you anything about hypertension? You people are much more better in dealing with hypertension, but it's the sponsor's, he has his own wishes, so we have to abide by the wishes. But yes, of course, I'm not trying to teach you anything, I'll just revise this molecule with you all. Maybe I will learn some things from you while we go on the way to discuss this new molecule. It's not a new molecule, but it is a very good molecule from hypertension and cardiac point of view, and of course from the nephrologist point of view also. Now let's go forward. Okay, देसी तरीके से करते हैं. Right, that's better. So, see, hypertension in India needs attention. Why? Because we try to manage the patients of hypertension very nicely, But what we have seen is, this is a large number of patients were studied, almost about 7 lakhs patients were studied in this group. And in this what they saw was, is my voice echoing or am I hearing an echo?
It's fine.
It's fine?
थोड़ा सा इको तो है, 2D इको है,
Is this better?
2D इको।
2 माइक है ना, एक माइक को बंद करो।
Is this better?
Yeah.
Now better.
I don't know
It
how
was
to
2D
close this,
echo.
otherwise I'll close it. Okay, this is better, right?
Yeah.
Okay, thank you. So, this was a survey which was conducted to find out how hypertension behaves in our country. And what they found was, interestingly, that the age group that where the hypertension occurred, it was varied from very young of 15 years to 49, 50 years. And only 7.9% patients had the blood pressure under control. Oh, yes, yeah. And about only 13% patients were treated out of the 7,30,000 patients. Only 13% were treated, and 44% were aware of the diagnosis, but they were not taking treatment. They were like, "हमारा blood pressure ठीक हो गया, हमने दवाई छोड़ दिया." And 76% almost were at least screened once in life for blood pressure, and they found that their blood pressure was high. So there is a lot of discrepancy about the hypertensive patients we have and the way we are treating the patients. We deal a lot with the patients of hypertensive heart failure, hypertensive arrhythmias like atrial fibrillation. We talk of cryptogenic strokes, like where atrial fibrillation occurs and there is no cause for it, but this is a very big cause for it. I have so many times seen that being combined with hypertension. So we need to control, we need to have a better control of hypertension. Now, the growing concern is that we are finding this associated with comorbidities like diabetes, that we are the diabetic capital of the world, right? So diabetes and hypertension they go hand in hand, and they form such a big 2 risk factors for coronary artery disease and stroke, of course. Increased hypertension in the young population, so the end stage, end organ disease, whether it is cardiac or it is nephro, the kidney disease, is very, very prevalent and common. And plus, the treatment dilemma, the right choices for drugs, when to begin the choice of drug and when to begin it. It is a big dilemma which has to be focused on. Why are the slides not changing on this laptop? क्या करके गया जनरेशन? अच्छा, anyway, कोई बात नहीं. So we have more and more younger patients. I am seeing in my OPD patients coming at 27, 28. Maybe you are getting even at younger age. The patients are coming at younger age. But I see so many, every OPD I see at least 2 or 3 patients who are very young, hypertensive. They don't have any other risk factor. Some of them don't even have a family history. But stress, the stress lifestyle that we have nowadays is governing over their hypertension, and they are getting hypertension. Many cases of isolated systolic hypertensions are coming, and they have the sinus rate is always on the higher side. So they have tachycardia associated with uncontrolled hypertension. Now there are early signs of CKD, end organ damage. Yesterday I had a patient in OPD. He came with a BP of 220 by 150 and came and told me that मेरा तो ठीक हो गया था, मैंने 2 साल से दवाई छोड़ दी है. And he was having some chest discomfort and breathlessness. I said, with this kind of BP, I can't put you on treadmill. He has to travel back also. He come from northeast. So I said, okay, let's do your angiography and find out, whether you have a coronary artery disease or not. And believe me, I told Vivek, I said, we have to do the angio today. What time are you coming? And we were just deciding that. And I got the report of his creatinine. It was 3.4. So his blood pressure had actually destroyed his kidneys already. Now at 3.4 we can't do angiography. We have to control his blood pressure, work out for the end stage renal disease, what is it going on, CKD hai, uske upar, how do we go about, what is the kidney size, what are the renal artery size. He was around 50 years old. So this is the way hypertensive patients present to us with such a varied picture, and you don't know what to do, when to start, which medication. Now, there is a higher prevalence of hypertensive in the urban areas. And basically, I attribute this to stress levels, to bad eating habits, and to not exercising at all. The work that we are doing nowadays with corporate, with all these corporates coming in with the stress that people are up against, and there is no exercise. All of us are couch potatoes sitting in front of the laptops. So that is all contributing to higher BP levels. And then many large number of patients are actually unaware, they are undertreated, and they are uncontrolled. So you have to basically focus on all these points and try to rectify these points. Well, here in hypertension, males are more prone. Like CVD, you know, the CAD, coronary artery disease, is more prevalent in Indian males. Similarly, hypertensive disease is more common in males than females. Some people may say that females तो tension देती हैं, तो उनको कहाँ से हो जाएगा? But maybe that is true. I do not know. Now, the management of blood pressure and hypertension, you all will agree with me that it comes at two levels. It comes at pharmacological levels and it comes at the non-pharmacological level also. If you do not accomplish one of them, you can never treat hypertension in a good way. Now, non-pharmacological methods, let's talk about it. Kindly give me what are the non-pharmacological things we have to do.
Weight reduction, salt reduction, yoga, meditation,
Stop cigarette smoking.
exercise, and chatting with your friends.
So chatting with your friends
Having
and
a-
yoga, I will put them in the same category of me time, relaxation time,
Having
which
a
we
drink
require.
daily because it will dilate your, it will act on T calcium
Reduce the
channel.
stress.
I would not suggest that to the patient, but yes, of course you are right.
One drink
If that
a day.
relaxes you, that is very good. One drink can relax you. So what he has said is that
Calcium channel.
you should decrease your weight. You should exercise regularly. You have to reduce salt.
Start
But
smoking,
please,
spirits. Yeah.
but please, what you have to do is, do not put the patient on a no salt diet. In elderly patients, that can give you a havoc. If you say no salt diet or even low salt पे वो छोड़ देते हैं. So please tell them to have a normal salt diet to avoid extra salt. How does extra salt come in our diet? When you use the table salt for your raita, for your fruits, for your salads, right? When you are taking pickle, achar, papad, chutney, three of these things, right? When you are taking that little namkeen with your chai, that adds to your salt. So these are the extra salt. Tell them to leave that. Please do not tell them to decrease salt in their diet. The khana jo kha rahe hain, please let them take a normal salt diet. Otherwise, they will present to you with a sodium of 119, 180, and they can even have seizures. I have seen people having seizures with this kind of a salt. And the answer that comes is कि डॉक्टर साहब ने बोला था salt छोड़ दो, salt कम कर दो, तो हमने सोचा कि कम करके ही खाते हैं, हमने सेंधा नमक शुरू कर दिया, हमने ये कर दिया. We have to be careful about what we are saying here, right? So. And sir has said एक glass drink ले लो. Spirits is a no-no for hypertensive patients. Smoking is right. It's a no-no for our patients. And yes, and for hypertensive patients I said. I didn't say you. And then what we have to do is that we have to have me time. Relaxation time really works in a very good way.
Even pollution.
Pollution, of course, now the pollution is a big factor.
Not only smoking, any form of tobacco.
Yeah, even tobacco, sure. So you're right, sir. Any form of tobacco. Absolutely right. Okay. So, hypertension management is more about combination therapy. It is no longer about just starting either a diuretic or an ACE inhibitor or a beta blocker. So whatever drugs we knew earlier, every year, every 2 years, they bring out JNC guidelines. पागल हो जाते हैं, दिमाग खराब हो जाता है, कितना पढ़ोगे? So what you do is, whatever you knew before when you were practicing about 10 years ago is all changed now. We have ARBs, ACE inhibitors or ARBs. ACE inhibitors as compared to ARBs are a little less potent to control blood pressure, but ARBs are very good. Right, we have our data. I will not go through those trials. I will not bore you with those. You all know about them much more than I do. and CCB combination. That is a very, very good combination to start the patient as an antihypertensive drugs. If the blood pressure doesn't get controlled, then you add a diuretic. And if it is a resistant hypertension, then comes the role of either alpha blocker or a beta blocker. That means centrally acting drugs for blood pressure or beta blockers. Beta blockers have gone way down in the management of hypertension because more and more we have realized that hypertensive heart disease is a havoc. You are facing a challenge with the diastolic heart failure nowadays. More than systolic, we are seeing diastolic heart failure, and the very important cause of diastolic heart failure is the relaxation abnormality or hypertrophy, which occurs because of the LVH, which happens because of uncontrolled blood pressure. So your heart forgets to relax. The best drugs to make them relax are actually calcium channel blockers. And the Silacar has a role in that. So it will give, you make your heart to relax. So symptomatic benefit happens in these patients. Beta blockers are in fact not a good drug to be used in diastolic heart failure. Over the time we have had quite a proof and quite a data on this. Henceforth, they have gone down in the management of, there are very specific places where you want to give beta blockers and you want to give diuretics as a next chance. So basically, we are we are starting a combination of ARBs and CCBs. Now, over the time, we've had these calcium channel blockers, and they have progressed. Somebody was asking about Nicardia, right? Where is the position of Nicardia? So nifedipine has been there, Nicardia has been there, amlodipine, of course, our good old amlodipine has been there. But amlodipine, there is a very important thing that you need to know about amlodipine. One, it gives ankle edema, angioedema. Secondly, it has no cardiac benefit to be given. It controls the blood pressure, but there are no cardiac benefits per se with amlodipine. Dilzem, good old Dilzem gives you constipation, controls the rate, but it again does not help much about the control of blood pressure. But with this fourth generation CCBs coming in, there has been a real very good change in the management of heart function. Yeah. Okay. So this chart is just showing the comparison of first generation to second and third and fourth. So what you need to know special about CCB is that it is a strong medication, its onset is slow, it lasts longer. So even if patient misses a dose in the day, we give it twice a day, it will last, it will give us more coverage. But most important of all, and we'll discuss this in a little more detail, there is no tachycardia with this. CCBs caused reflex tachycardia. Amlodipine, Dilzem controls the rate. Dilzem is meant to control the rate, it does that. But rest of them, nifedipine, people who have been using nifedipine, people who have been using amlodipine, patients have had reflex tachycardia. And to control that reflex tachycardia, we used to give beta blocker along with that. Amlong A, we have been using it for years together, right? So that is there. But it is not there with cilindapine, and that is very good because it does not activate the sympathetic system. Right, there has been some data about how well it controls the blood pressure, and it has been worked up in about 2,300 patients done by the clinical practitioners. They looked at the ambulatory BP control and the home monitoring BP control for a follow-up of 12 weeks. And what they found was that the morning systolic blood pressure got controlled better with cilindapine. And of course, the heart rate, the pulse rate was not, there was not reflex tachycardia, it was well controlled while cilindapine was given in these patients. And what about the vascular and end organ protection? Well, cilindapine does a good job in that also. This is an Indian study which was done in Andhra Pradesh on 60 patients, follow-up of 8 weeks. And on the blood pressure control with amlodipine and cilindapine, amlodipine versus cilindapine, right? And it was shown that cilindapine actually reduces the arterial stiffness and central aortic pressures. It also reduces LVH and improves the function, and then it decreases the heart rate rather than giving a reflex tachycardia. So it is also, this study is also supported by a lot of data that we got over the time for cilindapine, and hence it has been shown to also reduce proteinuria as compared to amlodipine. Amlodipine does nothing for this, but cilindapine of course decreases proteinuria, and the tolerability of cilindapine is better since it does not cause reflex tachycardia, and there is no pedal edema with cilindapine, which we get very commonly with amlodipine. Patients come with literally swollen feet sometimes, if we're giving amlodipine alone. And ARBs and cilindapine form a very good combination to reduce blood pressure in renal patients and patients who have diabetes, and in all patients also, whether whichever is the any other high risk patients, it is shown to be better. This combination has been shown to be better. So let's try with starting this and keep the patients on this so that we get better control of blood pressure in patients. And definitely a combination therapy is better than monotherapy. You should be starting these patients on combination therapy. In fact, it is said that in case you started a patient on an ARB, a single drug you have started, and the blood pressure is not controlled, it is said that you add another drug, another class of drug, like ARBs is one class of drug. You don't increase the dose of ARB. If suppose you're starting them on telmisartan, 40 mg twice a day, don't increase it to 80. Add CCB. Add a maybe a beta blocker, add a diuretic to the patient. Don't increase one drug, depend on the combination therapy rather than a monotherapy for better control of the blood pressure. So thank you so much for your patient hearing. This is all I had to say. And thanks for having me here, sir.
Thank you, Dr. Vanita. We have second talk by Vivek, and let's have the question answer at the end of the talk. Dr. Vivek is going to give us a talk on what? Heart failure.
I told you both the people, interventionist and
I know.
उसको बंद कर दे.
नीचे से स्विच नीचे कर दो, नीचे कर दो.
हाँ.
Very good evening to everybody, and thank you very much to the Physician Forum for giving us this opportunity to discuss. Hello.
This is right.
Hello. I'll start it. So I was just saying that good evening to everybody, and thank you very much for this chance, this opportunity to discuss these relevant topics regards to the Physician Forum and all the distinguished physicians who are sitting here. So I am Dr. Vivek Kumar. I am a senior consultant at Apollo Inchpress Apollo Hospitals, and as Dr. Chauhan introduced that earlier, we were at Max Arcade. So I was with Dr. Vivek Kumar and did a lot of great stuff there, and I'm aiming to do some even greater stuff at Inchpress Apollo. So I am a structural heart interventionist who does intervention in coronary interventions and a part-time EP person also. So the topic we are going to discuss as following Dr. Vanita's topic, heart failure reduced ejection fraction in 2022. So just I'll be discussing a few points here. So we know that heart failure is a problem that it's not changing here in the laptop, no? It's just there is a problem.
I don't know, something he has done. You have to look at that. बीच में अपने आप ही ठीक हो गया.
नहीं, I think इसे ही पढ़ा.
Okay.
Press the down button.
The slide is not moving here, it's just moving there. That's such a. Anyways,
It's AV dissociation, sir.
yeah, it looks like. Maybe a hyperkalemic effect. There is a P wave. The sinus. Usually in hyperkalemia, what happens that we have a sino-atrial conduction, that it's concealed. The rhythm is sinus, but there is no P wave apparent. So यही हो रहा है. यहाँ से मैं click करूँगा, ये move नहीं करेगा, देखिएगा नहीं, but ये move करेगा. Let's see. So heart failure. We all know about heart. It's echoing.
दो माइक वहाँ पे ऑन है.
दूसरा बंद करो।
या अब ठीक हो जाएगा दूसरे माइक.
नहीं सर, दूसरा माइक नहीं है, दूसरा माइक
यहाँ पर इसको ऑफ
इसको
करो।
ऑफ कर दो.
या
ये यूज कर लो उससे कर लो।
Yeah.
ये इसको एक ऑफ कर दो ना.
Hello.
बेटर है.
नहीं हो रहा।
नहीं अब वो हट जाएगा.
Yeah.
कर दो उसको.
No, it's okay.
Hello.
Yeah.
Okay. So we know about heart failure. We all know, we encounter patients of heart failure, and we know that it is something which really impacts us heavily. I always say to people that if you give a diagnosis of cancer to somebody, the reaction would be that all hell is falling on him and जमीन खिसक गया, मतलब पैर से जमीन खिसक गई. The reaction will be like that. But if you say somebody, a patient walks to a clinic and you say आपका ejection fraction 40% है. Okay, ठीक है sir, तो सब ठीक है ना sir? Usually this is the way the patient, it's all good na sir, I think we can manage this. So I just want to impress one thing is that a diagnosis of cancer in a lot of cases will be prognostically much better than a diagnosis of heart failure. Once a heart failure, always a heart failure. And believe me, the data says that the 5-year mortality of heart failure is 50%. And we now know a lot of cancer survivors surviving more than 10 years, 9 years. Even my father-in-law, he had a CA colon operated, he's fine 6 years, he's doing fine. No therapy is needed. But if you have a heart failure patient, you have going to have a lifelong medications for heart failure. So it's very important to prevent heart failure. So we know, all understand that it's deadly and it's costly. The kind of financial burden that it has on the patient's budget is, it's great. We know that heart failure medicines, we have new medicines coming in, and they are not cheap, they are very costly. So diuretic heals, I think, is a medicine which comes at a very low cost, but all other medicines are really costly. So the unique thing about heart failure in Asia is that the Asian patients are younger, and the reason for that is we all know. Why? Because we are the diabetic capital, we have the maximum number of hypertensive patients, and now we are having a lot of people who are sitting in corporate offices, air-conditioned chambers, not doing much, and going towards risk factors of CAD and having heart attacks and things like that. So we are a population where we have young patients of heart failure, and these patients are having more risk because we have more diabetic patients, more hypertensive patients, and more CAD patients. And we are having these patients at a younger age compared to the European or American population. So this is a very interesting slide if you see. That heart failure has an insidious disease, actually it's an insidious onset. It starts very silently. So if you see, we have 4 stages of heart failure: stage A, stage B, stage C, and stage D. Most of our patients will be stage A. So this is a stage where we have just the risk factors of heart failure. So interestingly, we can prevent heart failure at this stage from becoming symptomatic by preventing the risk factors. So stage A is a stage where somebody can be having a CAD, but a normal ejection fraction, a hypertension, some LVH, but no symptoms. Maybe the patient can have a valve disease, which is asymptomatic. And if we diagnose the patients early, we treat the risk factors, we will prevent the patient going from stage B that is having very little symptoms with deficiency in heart function, to a frank symptoms and even stage D, which is the refractory heart failure, where you have to have very desperate measures to improve prognosis, cardiac heart transplant, LVADs and all that stuff. So which is, the prognosis is. So it's very important that we recognize heart failure and prevent heart failure, and it's much better than treating heart failure, because if you see, I will share some slides that will highlight this important. So heart failure has a vicious cycle, and this is important. So once a heart failure, always a heart failure. What we do? We treat the symptoms, the patient has fluid accumulation, visits the physician office, we increase the dose of Lasix, maybe the patient may be treated for some days in emergency, goes back home, then again comes for hospitalization because maybe the dose of fluid that he is taking, the diuretic dose may have been tapered down, and again comes with chronic heart failure, and this is a vicious cycle. The importance of hospitalization in heart failure is very important. I'll emphasize on that. But before that, let's see this conundrum of heart failure, the donkey analogy. So you can imagine our heart to be like this. A failing heart is like this. What we do? What you can see, this donkey is overloaded with this burden. He is weak, and what happens in heart failure? This slide actually narrates everything, all the pathophysiology that happens in heart failure. In a heart failure, the heart is preloaded, and there is a lot of vascular resistance because of other factors. It's very hard for the heart to work. The contractility of the heart is reduced, it's not able to work efficiently, and there is a chronic sympathetic activation. So imagine a washerman's donkey. He is weak, overburdened, a very not a good road to walk in, and you have a chabuk of the washerman hitting the donkey that you have to work, and progressively there is the donkey will collapse. So this is what happens in heart failure. Our heart is preloaded, there is lot of afterload, the contractility is decreased, and at the same time the sympathetic activity makes the heart work. You have to work more and more. So most of the heart failure patients have a high heart rate, and ultimately there is a remodeling and you have a cardiac arrest and end-stage heart failure. So this is the donkey analogy that works, and most of the treatment options are targeted to all these pathophysiological effects. So what are our goals of heart failure therapy? It is to increase survival. So increasing survival becomes very important. Reduce hospital admission. I'll show you slide why hospital admission is reduction of hospital admission is very important, and make people feel better. You have to give them some hope, some symptomatic relief. So these are the goals that we strive to achieve. Most of the time we are able to achieve this much, but for some short periods, because most of the patients will have reduction in hospital, will have repeated hospital admissions, and with every hospital admissions the chances of survival is reduced. And the drugs, we said what we do. So diuretics, what it does, it decreases the preload. Okay? ACE inhibitors, ARB, what it does, it reduces the afterload. Beta blocker, it proves the sympathetic, hyper-stimulated sympathetic system. Aldosterone, antagonists, all these what they do, they improves the cardiac remodeling, and this is how we work on the heart failure treatment. And additionally, we have these devices, CRTD, ICDs, for further optimizing heart function and preventing cardiac arrest. And there is some role of combination of hydrazoline with isosorbide dinitrate, and this is the biggest chabuk that we give in the end, that digoxin, which doesn't have any mortality benefit, but definitely the patient symptoms may improve. So this is how we treat heart failure. And does it work? So coming to this slide, if you see that in a heart failure patient, with every progressive day, the patients have this course or natural history, and every hospitalization really makes the patient susceptible to having adverse event. Even if he survives, he may stabilize for some day, but this will be a downward course, and ultimately it will reach in mortality. And that's why we say that the 5-year survival in a heart failure patient is just 50%. So a heart failure patient who walks into your cabin, maybe there's a 50% chance that after 5 years he will be not there to visit you. So it's very important that we reduce mortality and reduce the patient's survival. So this is the data that we have, the pillars of heart failure treatment that we have been using for the last so many years. ACE inhibitors has a 16% relative risk reduction. ARB showed in CHARM alternative 23%, beta blockers 34%, and mineralocorticoid receptor antagonist 30%. So this is a relative risk reduction of all the medicines that we have been using for so long, but still our patients deteriorate. They decompensate. They come to our emergencies with heart failure symptoms. So we had these new drugs. Evaporating, we know the data that it's very important to give the heart a chance to breathe. We need to make the heart rate slow, and in the shift we found that adding evaporating to patients whose heart rate is not less than you're not able to achieve less than 70. If you add evaporating to such patients, these patients develop have improvement in reduction in events of hospitalization and mortality. And then we have the paradigm trial, the angiotensin receptor naproxen inhibitor, the Vimada, the famous Vimada, the drug that really changed heart failure management to a large extent. And you have role of intravenous iron also. So these were the new medicines that came up over the last 3-4 years that further improved patient survival and reduced hospitalization. So if you see here, this trial, the Paradigm HF trial, was a very landmark trial because this was done compared to enalapril, which has been for a long basic pillar of heart failure management. And despite being on that, the ARNI showed about 20% more reduction in heart failure, hospitalization, and death. So this means that if you have to choose medicine, angiotensin receptor antagonist or ACE inhibitor or ARNI, it's important that we choose ARNI in place of these molecules in a heart failure patient. So now in 2022, what options we have? So we had data with ACE, ARB from these trials. We have data on beta blocker. So in this, it's very important that we choose the right beta blockers. So we have data for metoprolol, we have data for bisoprolol, and we have data for cardiolol. So these only 3 beta blockers are recommended in heart failure patients. No atenolol. We have very limited data of nebivolol. So these 3 molecules and these trials on respective molecules, beta blocker are there for. So if you have to choose beta blocker, you have to choose between bisoprolol, metoprolol, and cardiolol. So these are recommended. And then you have data with spironolactone and ipranolol in emphasis HF trial. So these were before 2020 or before that. Now what new molecules are there? So we have naproxen inhibitor, the data is from Paradigm HF, SGLT2 inhibitor, which we are going to discuss about why this molecule is so unique and so effective in heart failure. And another molecule we are soon going to have it, which is the Versigouat, which is a CGMP stimulator. We have data from Victoria trial, and evaporating we discussed. So if we see from 4 drugs, we have these sets of 5 drugs that can make heart failure management more effective and maybe more reduction in heart failure, hospitalization, and mortality. So we can say that we have 5 allied pillars today. We have to choose between ACE inhibitor, ARB, and naproxen inhibitor, that is ARNI. We have to choose this. Then we have option of beta blocker, MRA, and SGLT2 inhibitor. Why SGLT2 inhibitor and what's so unique about, and in this I'll just go on to this molecule now. So SGLT2 inhibition in CV disease, we all as physician and cardiologists, we know that diabetes is an important disease that causes risk factors and leads to heart failure and MI. SGLT2 inhibitors started as a diabetic therapy, but the initial trial showed that patients of diabetes who were getting SGLT2 inhibitors had lesser hospitalization for heart failure compared to other patients. So this led to research that why is that SGLT2 inhibition is helpful. So I'll just give you a brief likely mechanism why SGLT2 inhibition is so effective as a heart failure medicine in addition to diabetic treatment, because SGLT2 inhibition acts as, I'm just going to finish with this.
Yeah, we can ask some questions.
Yeah, definitely. So the important aspect of SGLT2 inhibition is that, as we said in heart failure, it acts to improve preload, decrease afterload, and also works on heart. So this is how this molecule works. And which molecule to start with? I mean, just this slide. This will be my last slide here. So we have options. We can start with the SGLT2 inhibitor to first go, or we can use it as an add-on for our patients. And these are the basic drugs that we are going to use in heart failure medicines. And I think we can discuss how to start with individual questions. Thank you.
Very good. Can we have the lights, please?
Yes, sir.
लाइट्स
You are unlikely to start.
इधर आ जाए सर.
All three of you there. Vanita?
Thank you, Dr. Vanita and Dr. Vivek. It's a very nice talk. Vanita spoke on hypertension, management of hypertension.
Lights.
And Dr. Vivek has given very good overview of the heart failure and to prevent heart failure to go into the further complication and hospitalization. Thank you very much for both of your talks. And now we have stalwarts to ask questions for you. Please, both of you come inside.
Sir, kindly be seated, sir.
All three of you there, sir. You must have a mic. I won't need a mic. Is there a mic? An additional mic, please?
Mic है क्या एक और बेटा?
Mike Tyson.
What about that mic? Can we take that mic?
No, you're quite loud.
Okay, great, sir.
Quite loud. You can
वो मूव हो जाएगा बेटा? वो वाला माइक मूव हो जाएगा? हाँ,
आगे रखो.
बहुत बढ़िया.
उनको दे दो.
वो वाला माइक वहाँ पे रख दो बेटा.
NK.
वो वाला माइक वहाँ पे रख दो. Makes lot of sense. उधर रख दो बेटा उसको माइक को.
Thank you, sir.
मेरी ये सीट है यार. हाँ.
Sorry, sir. I just forgot to introduce Dr. Vivek formally. When we started.
You could introduce now.
I can introduce now. Dr. Vivek is. Read up. Thank you, sir.
ये बंद कर दो बेटा. ये बंद कर.
Let me take the honor to ask him to introduce himself.
I think I am somebody, as I said, that I work as a senior consultant at Apollo Hospitals, and I started my journey in 2012. I worked at Max Arcade. So I have done my MD-DM from BHU Pharmacy. I have been to Cleveland Clinic for structural heart observership, and I have experience of structural heart disease intervention for the last 2-3 years. I do coronary interventions, all sorts of complex interventions I do, and with Dr. Vanita we do complex EP studies and ablations too. And I mean, this is something not much. I like to publish papers. I'm very inclined at academic activities, and this is what I can introduce from myself. Thank you very much for it.
Thank you. Very good. Brother, this guy is an expert in travel. He's a lot of travel there, and he has an excellent record of interventional procedure and a good result after that. And a wonderful human being. I had interacted shortly with him, and I'm very happy to meet you, sir. God bless you. Over to Dr.
Thank you, Dr. Mathur, sir. So, nice talks, Dr. Vanita and Dr. Vivek as well. So, Dr. Vanita, less than 14% of the world population have adequate BP control in developed countries. Less than 8% are controlled in developing countries. So, is this there a clinical inertia in starting of medicines for hypertension? Please tell us.
Sir, it is, I think it is both ways. There is inertia in starting medicines. Younger population is coming, so we are a little scared to start the medication, when to start medication, whether we should do it or should we wait for the lifestyle modifications to take over, diet control kar le, salt kam kar le. And in addition to that, it is a very low compliance on the patients also. I have seen more of it, it is not on the doctors, they start on good medicines, but if you start on 2 or 3 combination therapy, patients generally either they give up all the medications or give half of the medication. So I think I'm not a very big fan of taking tablets, with combination therapy, a single tablet with, like they have Silica TM, right? So there are 3 drugs in that. I'm not a big fan of this, but I have started doing this for my patients. Because if I write, the telmisartan separately, Silica separately, beta blocker separately, they will end up taking 1 or 2 of those medications. That invariably they will leave. But if you start this combination therapy, probably they will end up taking it.
So you're very right, because when I see patients of hypertension and prescribe them medicines, and ask them to come back to me after maybe about a month or so, to never come back. They come back after a year and say, you were given medicine for 1 month and my blood pressure was under good control, so we stopped the medicine. Invariably, they come to us with complications. So, Dr. Vanita, tell us a little about, apart from hypertension control, you probably need to also modify CVD and renal risk factors like diabetes, like dyslipidemia, like obesity and OS as well. So,
diabetes needs to be controlled. Initially, as Dr. John was saying, we had a drug which was no longer in the armamentarium of management of diabetes, but we have very good drugs now. We have SGLT2 inhibitors. We have not only the gliptins, but we have the, what is the other one?
Semaglutide.
Correct. Glutides, right?
So GLP-1 agonist.
Oral
Absolutely. These are, the names are such a tongue twister. I am unable to pronounce them. I'm sorry about it, but I'm unable to pronounce them.
That's fine.
And there are so many good drugs available. I mean, you have their control, their presence in heart failure, in diabetes, in cardiac patients to reduce CVD mortality. I mean, it's a beautiful thing that you see with these patients, the gliptins that we see and the SGLT2 inhibitors that we see. So, control of diabetes is very good. I insist on a HbA1c of 6.5. My endocrinologist friend says, no, keep it at 7, but I keep it at 6. If you target 6.5, you reach at 7. If you target 7, you will reach at 7.5. With patients, the control has to be this much. And yes, the reduction of weight is very important. If you can make the patient to reduce their weight by 5 to 10 kgs, it makes a gross difference on the control of hypertension, on reduction of CVD risk in these patients. And you wanted to know what else about CVD per se?
So no, I'll limit my questions to 2 more to you because I have a lot of questions to ask to Dr.
Please,
Vivek.
go ahead.
No. First 2 questions to you.
Sir, I'm not a big talker actually, I just want to keep quiet.
That's okay. So, ARNIs versus ARBs versus ACE. See, 3 million patients data available now, talking about ACE and ARBs. So no statistically significant, benefits between either of them, but the side effects with ACE like angioedema, like cough are seen more. And then what about ARNI? Jack said this is the drug to be given. It reduces heart failure, it reduces all-cause mortality as well, reduces EV mortality as well. And finally, so what about the hyperkalemia? See, when you combine ACE with MRAs, MRAs are the drugs to be given, especially in resistant hypertension. So when you combine these two drugs, the hyperkalemia is a big problem. So, do we have anything for hyperkalemia now?
Sir, the data that I know of ARNI, it has shown that the hyperkalemia does not occur over and above what it used to occur with ACE inhibitors and ARBs.
No, ma'am, I'm talking about ACE, ARBs or ARBs plus MRAs. So hyperkalemia is a big problem.
Yes.
So I'm talking about the diamond study here.
Yeah,
So,
right.
see the Petirumavir, which is the new non-steroidal MRA. See, it reduces hyperkalemia and allows us to continue at least 85% of the patients to continue.
Amazing.
Yes, this is an amazing and a significant pharmacological advance. So I'll end my questions to you, Dr. Vivek.
Sir, if you permit, I just
Yeah,
like
please.
to add
Please.
about this
Yeah,
hyperkalemia aspect.
yeah.
So, sir, definitely when we are choosing ACE, ARB, and MRA in a patient with hypertension, I think MRA is reserved for patients who are having resistant hypertension. So we have to add it last. So before that we can use alpha blocker and beta blockers and stuff like that. We don't have any data for ARNI in hypertension. Paragon HF trial failed miserably to reduce, show significant reduction in 40%. I think there is a no role of ARNI over and above our ACE or ARBs. So I think just I wanted to add this aspect.
Okay, so Dr. Vivek, so all the four, would you say disease-modifying drugs or prognosis-modifying drugs? I'm referring to the four fantastic drugs, the SGLT2 inhibitors, the MRAs, the not diabetics, the beta blockers, and the ACE and ARBs. See, so these are not only disease-modifying drugs, these are also prognosis-modifying drugs as well. So, how do you sequence these drugs?
Sir, okay, so that's a very beautiful question, sir. So I'll answer that question based on my personal experience. So if you ask me that what should be the first drug that you should start in a patient of heart failure, we must see two things. What's the pulse of the patient and what's the blood pressure of the patient. If the patient's pulse is high, the BP is high, by high I means it is more than 120 or it's a normal 120 by 80. You can start all the four components, beta blockers, ARNI, SGLT2 inhibition and MRA in such patients safely. The beautiful thing about SGLT2 inhibitor is that the question of hyperkalemia, I think in the Emperor reduced trial it was shown that if we use SGLT2 inhibitor with an ARNI and a mineralocorticoid receptor antagonist, the chances of hyperkalemia is less. So this is very important. And the most important aspect, if you ask me, I have some reservations for Paragon HF trial. If you see the details, only 70% of the patients were having MRAs. And the data that I showed, compared to ACE, ARB, beta blocker or MRAs, the maximum reduction in relative risk reduction is with MRAs. And I'll really emphasize on this point that MRAs are the most unused drug in heart failure.
Yeah, correct.
You will have patients on Ditor, but not on Aldactone or Eplerenone. So it's very important. And coming to second question, what if our patient is having a borderline of BP, say for example 99 by 60 or 50 with a high heart rate? You cannot start a ACE or ARB in that patient. You cannot start a beta blocker. Believe me, starting SGLT2 inhibitor in such patient is worth. I'll share a patient, there is no recommendation of SGLT2 inhibition in acute heart failure post-MI patient. I had one 70-year-old gentleman presented with stent thrombosis I did his primary and his BP was 90/60. His chest was congested. I could use very low dose of diuretics. I was wondering how I can up titrate the patient. I just, by reflex, I thought let's take a chance. We don't have data of SGLT2 inhibitor. I started Jardiance in this patient, and believe me, his pulmonary edema was reduced on day 2, and then the patient's dose of diuretics was not required. His BP improved, and later I could add a army in this patient and can discharge a patient. So I think this should be our sequence of medication.
So I think you're probably referring to the Solaris trial, which was used in acute decompensated heart failure.
Definitely, sir.
You see, you could start SGLT2 inhibitors right from the first day.
Yeah. So
I think you're referring to the Solaris trial.
We don't have data from post-MI patients. So that was a post-MI subgroup that I started, because at that time we didn't have data of Solaris, but acute MI still we don't have recommendations. So we have to be very cautious, but I have experience in 3 patients, and I have seen that starting SGLT2 inhibitors reduces the need for diuretics, and it's very important that before you start, you please assess that do your patient require the same dose of diuretics or not, because if you don't, there are chances that patient will land into ketosis. So it needs to be really carefully titrated.
So finally, consistent positive findings from the 3 very dramatic trials I am referring to, the Deliver, the Emperor and the Chief Heart Failure trials. So all had a compelling story to tell, and what did they say? They said the benefits of adding SGLT2 accrue very early. See, and you must start this medicines right from the first day. So finally, Dr. Vivek, tell us, is it so important to measure an ejection fraction? See, all these drugs can be used across the broad spectrum of heart failure, irrespective of ABCDs or NYHA class 1 to 4. So, because we know ejection fraction is a variable biomarker, and these drugs can be used across the spectrum of heart failure. Tell us, sir.
Sir, so in reduced ejection fraction, no doubt SGLT2 you can start at any point. The day you think that the patient is having a heart failure, you can start SGLT2 inhibitor without bothering about the patient deteriorating or having any adverse events. But one few things I like to caution, that whenever one is starting SGLT2 inhibitor in a heart failure patient, it's always important to assess the need of diuretic. And if you are thinking that you are going to start SGLT2 inhibitor, please reduce the dose of diuretic when you start. Second, I have seen that in acute heart failure situations, if you start SGLT2 inhibitor with a metformin, we have a lot of combinations now, DAPA metformin and IPA metformin combinations. Please, in diabetic patients, be cautious. I have seen 2 patients at least landed with ketosis because of these 2 combinations and a diuretic. So we have to just see how dry our patient is, and based on that we can start SGLT2 inhibitor at any point. One thing more, that message should not be like this, that any patient who walks with shortness of breath is a heart failure patient. So I have seen patients having COPD being prescribed SGLT2 inhibitor also without having diabetes, just because the patient is having shortness of breath. So diagnosing diastolic heart failure is in itself a task at hand that needs to be ascertained before starting a drug like SGLT2.
Finally, Circulation published last month, and it said that SGLT2 inhibitors reduce ventricular arrhythmias and also the chances of sudden death. Not only that, they also said resuscitated cardiac failure, resuscitated cardiac arrest were also less when you use SGLT2 inhibitors. And what else? Also, the HS-trop T, probably, see, higher the HS-trop T, the more the benefit seen with this SGLT2 inhibitor, sir.
Sir, the
This is published in Circulation.
Yeah, definitely, sir. So the mechanism of action is still hypothetical. We don't know the mechanism of action. So if you ask me why SGLT2 inhibitors are so good at reducing symptoms of heart failure, we have things to explain, the way it acts, but how does it really impact on these aspects of reducing arrhythmia and improvement in outcomes is I think it needs to be something we need to find out.
By diminution of the probably cardiac metabolism or something like that. Thank you, sir.
Thank you, Dr. Tulsi.
I will take less than 1/4 of his time. So, as he was referring to Solaris trial, I was reminded of what we were discussing, Leonardo Solaris of Dark Desires. Sir.
They must not have seen Dark
Okay,
Desires.
sir. Just my first comment, and I may have a bet with him. Alcohol acts as a calcium channel blocker. It acts on T channels. So anyone has any doubt can have a bet with me. I am ready to lose 10 rupees. Sir, poor control world over, and more so in the developing countries like we can't say India is developing, it's now developed. Still, basically it is the lack of awareness. How many go for the BP checking? It's only when there is insurance checkup or say employment checkup or somebody goes for a preventive checkup, which is not so popular as such. So we are not aware of our blood pressure levels, and those who are having told that you are having blood pressure problem, they will not take medicines once they find it's okay, unless they are having some problem, symptoms. Symptom-driven treatment is more, and medicine compliance is very, very poor. Sir, Dr. Vivek, I just want to know, Vivek Kumar.
Actually,
मेरे लिए तो आप तो मेरे लिए लेफ्ट एंड राइट आईज हो ना, मैं आप दोनों के साथ
that's actually one of the important reasons of taking maths.
Both of you.
So ये मेरे विवेक का अज्ञान था. मैं आपसे जानना चाहता हूँ कि which stage of heart failure is reversible? Stage 1, A, B, C, D, whatever you said, four stages. Up to which stage is reversible? I know diabetes is reversible at certain level. If it is due to your say lifestyle, it is reversible 100%. I can guarantee you, if it is due to your overweight, hypertension also is reversible. If it is due to
What stage?
I am saying what?
Yes, sir, I understand.
Up to what stage?
Yeah. Sir, stage A is the stage where you have risk factors for heart failure,
Yeah.
but the heart is not diseased. So stage A is totally reversible. You can control your risk factors, so you prevent heart failure from happening.
So.
Then stage B. So stage B is a stage where a person can have a valve disease, for example, asymptomatic severe AR, asymptomatic severe AS. The patient can have a CAD, having triple vessel disease. So if you treat the valve disease, if you treat the CAD, you are going to reverse heart failure. So stage A and stage B is the stage where you have maximum to gain, and we must identify such patients and do action.
Sir, with due respect, as you said, once a heart failure, always a heart failure is reversible also. It may not be always stage 1, stage A or stage D is reversible. It's a good thing. We should try to reverse it.
So just to add on that,
Yeah.
so it's reverse. Once a heart failure, this is the reason I said that, a diabetic patient is going to be diabetic for his whole life. He needs to take the measures appropriately all life. A CAD patient is going to be a CAD patient all life. He needs to take measures, takes antiplatelets so that he doesn't have a stent thrombosis or graft failure. A valve patient can have a valve inside. We know that the patient needs a acetron lifelong. He will, if he is not compliant, he is going to have a heart failure. So this is the reason I said that once a heart failure, always a heart failure.
Agreed, sir. Once a liar, always a liar. Sir. Iron therapy.
Sir, I think what he has insistently, very rightly said is, once the patient has been put on heart failure treatment, much like hypertension, if the ejection fraction improves, patients tend to leave their medications.
I agree and
And
take
it
your
should
point.
not be done.
Yeah. So
It should not be done.
one has to follow the protocol.
That's correct.
Not to take own decision. I'm just asking my last question. IV iron as a therapy, is it a must to get an iron study first, or it's a empirical to be given to others?
Sir, definitely it's not important to get iron study before giving IV iron, because if you see most of these patients, the trial didn't really, the trial was not based on iron study. What it showed that the patient had low hemoglobin, and you will find in most of these patients, I think MCV is a very important criteria. So if you find the MCV less than 90, you don't have to really go for any other study. You can safely give an iron and you will find the patient are having improvement. Definitely if MCV is high,
Advisable to get an iron studies done, sir.
Sir, MCV can be low due to thalassemia.
So
It's always better to get an iron studies
So
done.
I'll just put a different view on this. So
We have to agree or disagree.
yeah, definitely, and I totally respect that. So I just
These are the indications.
Yeah.
Let's
So
have dinner.
yeah, just one point I would like to really impress upon what I said is that suppose there is a body lying in a body in a pool of blood, and there's a man standing, and there is a knife by the side of the body. So anybody who enters this hall, there is a high likelihood that the person standing with a body and a knife is the murderer. In almost more than 90% cases. So if you ask me in heart failure patients have cardiac cachexia. They have, because of edema, their absorption of iron is diminished in the intestine. So there is a high likelihood that this patient is having nutritional deficiency of iron. So, and you know, iron studies are very costly. So if you go for, at least in Apollo I know.
Even CKD
So-
could cause, no
Yeah,
iron.
so-
So better to have an iron study.
Definitely, sir. But
No harm done.
definitely, but if the patient is having a normal creatinine and the patient's hemoglobin is 8, I will not like to advise the iron study. I will instead say give a iron dose. Most likely the patient's hemoglobin should
Anyway,
improve.
that can be,
Yeah,
my
definitely.
both
Right,
can
sir.
be done.
I think some questions, simple questions, sir, I think for everyone's interest. First to Dr. Rita. Ma'am, we did not have JNC 9 for a long time, and JNC 8 took very long, and some people called it JNC late rather than JNC 8. And then the whole guidelines were blasted later on by a lot of cardiologists, including many from India. Now, the chart that you showed now, when a patient comes to us in our clinic without any contraindications, major contraindications to any of the group of drugs, what is the guidelines that we should follow for starting our patients on any antihypertensive? Can we have some decorum, please? I request all of you to please settle down here just for 10 minutes. Just the carry home points, please. Dr. Saurabh, aake baith jao. Dr. Manish, please. Call everyone, just for 5 minutes. Ma'am, how to start medications? It is still classically the diuretics, the ACE ARBs, the beta blockers, the calcium channel blockers, resistant hypertension, and then go to compliance, etc., etc. What is your way of treating hypertension?
Sir, I go the other way around. I never start diuretic as the first dose. I start either the ACE inhibitors or ARBs, and I give a combination of calcium channel blockers with that. Now, if the patient is having a lot of tachycardia, I may add a beta blocker. But if the patient is not having a tachycardia, is not in a very high blood pressure like 200, shooting up to 200, 180, and the tachycardia is not there, the rate is well controlled at 75, 80 beats per minute, then generally ARBs and calcium channel blocker combination is my to start with. And then, of course, I call the patient at 4 weeks with a chart of blood pressure monitoring. And then the next step, if the blood pressure still stays high, maybe you are adding a little diuretic there. I seldom go to central acting drugs like alpha blockers, but in very resistant cases I do have to start there. But otherwise, my first starting point is ARBs, calcium channel blockers, then beta blockers. then-
Ma'am, we were classically told that if you have a young hypertensive
Yes.
with elevated intrinsic sympathetic activity, start these patients on beta blockers. What are the recommendations today and what do you follow?
So beta blockers, in case patient is asymptomatic, not going into failure, then yes, you can give a combination of calcium channel blocker and beta blocker. I do not start beta blocker alone in even young patients because I don't think they are as potent to control blood pressure as we have. The potency of controlling blood pressure is more in calcium channel blockers and ARBs. So I do not start them as a single beta blockers at all.
Ma'am,
I love beta blockers, sir. Nothing against beta blockers.
so as I understand your recommendations, AS or ARB first, calcium channel blockers second, beta blockers third, and then maybe you diuretics. Alright, when do you label your patient as resistant hypertension?
When the continuous blood pressure comes to about more than 170 by 100, so then it is resistant hypertension.
And you have tried everything plus a diuretic, isn't it?
That's correct.
So you have to give a trial of a diuretic before you label your patient
Absolutely.
as a case of resistant hypertension.
And so this happens more in young, and I think it is a good idea to evaluate them for primary cause of hypertension. I don't see people doing that also. That is very, very important, to get your ultrasound abdomen done for suprarenals, to get a renal artery Doppler done, maybe check the renal arteries by an angio in case you are doing an angio, and get the urinary catecholamine levels done. Assess for the renal function tests also.
Ma'am, for the benefit of us all, there was a rule given for hypertension way back in 1950. The rule of half. Of all the hypertensives that you have, only half ever get detected as hypertensives. Of those who get detected as hypertensives, only half get to treatment. Of those who get treatment, only half get to continue the treatment, and those who continue the treatment, only half of those have target blood pressure. That brings us to only 6.25% of the entire hypertensive population who get to targets. Is this dictum true even today, or it has
So
changed?
that was my first slide which I showed.
Has it
Exactly
changed?
same status.
Has it
No,
changed?
You are saying 6.25, they showed the data of 7 lakh patients as 7.9%. So it's
So
just almost
it's just the
6
same.
and 8 is hardly anything.
It's just the same.
Yes.
Ma'am, now coming to this molecule itself, ma'am. We were very fond of using amlodipine.
Yes.
All the combinations, I will not name any brands, but all the major brands,
Yes.
they were combinations of amlodipine and atenolol. Dr. Mathur sir, Dr. P.K. Gupta sir, Dr. T.N. Rao sir, they have all their bread and butter based on that combination. Is it time to change? Is it time to change this combination?
Yes, I think we have much past amlodipine. We have seen the very, very positive effects of cilindipine. And I have shifted my patients from amlodipine to cilindipine.
Right. Coming to Dr. Vivek.
Yes, sir, thank you.
Some very basic questions, sir. We were traditionally told that you need to treat heart failure with reduced ejection fraction, the systolic dysfunction. You introduced a topic today of heart failure with preserved ejection fraction. That is same as diastolic heart failure, if I understand it correctly. Heart failure with preserved ejection fraction is same as diastolic heart failure.
To a bit, yes, and then no also. So, diastolic heart failure, we often, if you send a patient to for an echocardiography, you will say that there is a grade 1 diastolic dysfunction. Some may be brave enough to write a grade 2 diastolic dysfunction. Very rarely you will see somebody terminate as a grade 3 diastolic dysfunction. The thing is that it's not just diastolic dysfunction that is impaired in such patients. The strain studies have shown that the systolic function is also impaired in a different way. So it's not that I'll just give you an example of a patient just seen today. So she came for a preventive health checkup. TMT fine, echo fine, as it happens in a preventive health checkup. Whenever you go, things are seen very in a superficial way. Even if you get an echo done, it will be done by some most junior nurse guy. So thankfully, I still use my step. So under this patient is given a class 3 dyspnea on exertion at times. Not always, but at times. So I just auscultated that patient, and I could hear ejection systolic murmur. The hemoglobin was fine, so it cannot be hyperemic circulation. So I asked our very distinguished echocardiographer, Dr. Sharat Tandon there, that sir, please isko ek baar dekhiye, I can hear a murmur. So he saw that patient, and I also advised a pro-BNP in that patient. So echo may mention that grade 1 diastolic dysfunction, everything is normal. Today this patient came to me with a BNP of 1100, EF is normal, grade 1 diastolic dysfunction, and Dr. Sharat called me up, Vivek, isko LVOT is very narrow, the pre-graded is 20 mmHg, which is higher than normal. But you see, this will not cause heart failure. But biochemically she is having heart failure. If I go by a Framingham criteria of heart failure, she qualifies as a patient of heart failure. So you see, so not all diastolic heart failures are heart failure with preserved ejection fraction, and it's other way around. So we have to be really careful. Patient symptoms are very important, and I think your clinical sense also should prevail.
So that brings me to my next question. Are there any differences in the biochemical markers of systolic heart failure versus diastolic heart failure?
So, sir, definitely biochemical markers, you mean pro-BNP?
Yes, sir, the one you just...
Yeah, so there is not much difference, but definitely in reduced ejection fractions, you can have BNPs in thousands, 10,000, 20,000, something like that. But sometimes you will see that BNPs and anti-pro-BNPs are also significantly high, maybe in thousands, but not to that extent. But हमें यहाँ पे I think we have to really factor in the age factor. So we must be careful before when we advise a pro-BNP. It's not that all BNPs may be because of heart failure. So if the patient is having CKD, it's good to give a BNP instead of N-terminal pro-BNP. So if in CKD patients you rely on BNP compared to N-terminal pro-BNP because BNP is metabolized in the body and N-terminal pro-BNP is excreted to the urine. So in CKD patients, you can have a high N-terminal pro-BNP and the patient may not be having a heart failure. So in CKD patients, it's good to choose BNP as a marker. Coming to individual marker values, so any value of BNP which is more than 500 is heart failure, irrespective of age, CKD and whatever it is. For pro-BNPs, in young patients, any value more than 450 is heart failure. In young patients, above 55 it is 900, above 75 it is 1800. So these numbers need to be there in your mind when you diagnose or advise a pro-BNP.
So that brings me to my, logically, the next question now, sir. Between systolic heart failure and diastolic heart failure. Grossly, let's say with preserved and with reduced ejection fraction, is there any choice of drugs that you reserve for heart failure with preserved ejection fraction? Because the data we have with SGLT2 inhibitors, they are very good as you, with Emperor preserved, you know. But we do not have the same data with beta blockers. We do not have the same data with ARNI. We do not have the same data even with MRSAs. So if you have a heart failure with preserved ejection fraction, are we obligated to push them into SGLT2 inhibitors?
It's a strong yes. So I'll just give you a background of heart failure, just a brief background. Heart failure with preserved ejection fraction. So the unfortunate part is that we don't realize that the mortality with heart failure with preserved ejection fraction is equally high as in reduced ejection fraction. In some cases it may be further higher because there are chances that HFrEF patients are more obese, they may be having more uncontrolled hypertension, uncontrolled diabetes and dyslipidemia. So you imagine the risk factors that may be carried. So coming to the data of drugs, unfortunately before SGLT2 inhibitors we failed on each and every molecule. We failed on ARNI, we failed on beta blocker. Only Aldactone showed in TopCat trial that it reduces hospitalization. This we have data on dapagliflozin very recently and Emperor Preserve. I think these two molecules are game changers, and I think without doubt you should start heart failure with preserved ejection fraction on SGLT2 inhibitor, whether the patient is having diabetes or non-diabetic, and you will see the difference. And I'm sharing this with my clinical experience. I have seen patients improving, dramatically improving in their symptoms.
Dr. Mangla sir has a question.
Yes.
I wanted to ask that in diastolic heart failure, do you see the LV-ADP is high?
Definitely, definitely. The whole pathophysiology of diastolic with preserved ejection fraction is LV-ADP. So we must remember that our lungs are a low pressure system, and the only chamber which gives the pressure back to the lungs is LA. The normal LA pressure is never more than 4 to 12 mmHg. The time it increases above 15 mmHg, our lungs start getting congested. Above 25 mmHg, lungs is flooded. So you have a margin of 3 mmHg. So if the EDP is not increased, the LA pressure will never increase. So the EDP is paramount for the pathogenesis of heart failure with preserved ejection fraction. So EDP need to be increased. So how can we assess? I really request a lot of all of you that please insist whenever you send any patient for stress echo, ask your echocardiographer to get a stress diastolic dysfunction assessment also. It's very easy. They just have to see the E by E prime ratio. On exertion, if it is more than 15, your patient is having HFpEF. Unfortunately, people are not doing this. It's very easy to do. If they can assess a tissue Doppler in baseline, they can assess it after exercise, and believe me, you will be diagnosing a lot of patients with because it's SGLT2 inhibitor will definitely help your patient.
Any role of beta blockers in the BP? Any role of beta blockers?
Sir, if the patient's heart rate is high, definitely it has a role. But if it's not so high, we have data from the seniors trial where nebivolol was tried. It didn't show much benefit. So if your patient is having CAD, definitely it has a role. Otherwise, I don't see a much stronger role unless your patient is not tachycardic. So if you find that your patient's heart rate is more than 80, 90, definitely you should start a beta blocker. But otherwise, I will not really recommend.
One small question to Dr. Vanita. You see, hypertensive patient. Suppose a patient comes to your clinic, he has a BP of 140/95, 140/100, 1 or 2, and rest of the time it's all right. Can you equate it to intermittent AF? That these patients are at risk of, you see, stroke like in intermittent AF they can have. And similarly, these patients who are hypertensive at times, you see, they will be throwing their BP very high at times. So they should be controlled with medicines, rather than giving them a chance, hitting with that. And is the increased salt intake, you see, is responsible for drug resistance to antihypertensive?
So what I understand, you have asked me two questions. The first question is, how is hypertension related to atrial fibrillation?
No, I'm saying like AF can result in stroke, intermittent AF.
Yes, sir.
Is a risk
Absolutely.
factor. Similarly, episodic hypertension in the patients, you see, whose BP is all right, and at times it's high. Maybe when they are angry, it jumps. So these patients are also at risk of stroke.
Yeah, so that is a very tricky population to manage. When that patient is having intermittent spikes of blood pressure hikes, right? And if you do not put them on medication, they will keep on having this, and the incidence of atrial fibrillation goes up. You were just discussing about LV-EDP in diastolic heart failure. So in hypertensive patients also LV-EDP goes up. The LA size increases. There are stretch receptors in the left atrium, which are the trigger points, which give PSCs and they cause atrial fibrillation. So the cascade is going the same. Hypertension and atrial fibrillation, especially if you have spikes of hypertension and you do not control them, it will result in increased incidence of atrial fibrillation, which leads to, of course, increased incidence of strokes in these patients. I totally agree with this.
Friends, I think we had a wonderful CNE. Let's give a big hand to our speakers. I would in the end ask Dr. Mathur sir, last word from him to summarize this for us.
I think we have already gone through a long session, interaction session with the audience and everybody. A lovely talk by Dr. Vanita and Dr. Vivek. Thank you so much for giving enlightening us on the both the subject. Hypertension is a very, very common topic, issue with our practice. And we do see very often hypertension patients and how to treat and when to start treatment. Thank you, ma'am, to give us time. One last question, a patient, I saw a patient in the morning, around 7:30 in the morning in my colony. He said, I have a little headache, his BP was 170 by 100. First time. Never had any problem. He traveled back from USA 2 days back, no other complaint. Now, it's a very difficult decision to start antihypertension on the very first shot. 62-year-old man, no other complaint. What is your take on that? Should we start or monitor them? We should monitor them for some time.
Sir, he's had a history of travel. 48 hours ago he traveled. There must have been stress. So I would not leave him at 170/100. I would give him, start him on a medication, maybe a very low dose, and then check his BP.
Anti-hypertensive?
Yes. Yes, I understand.
I should give a rest and give some anti, like HFrEF.
But sir, it is scary. 62 years of age, 170/100 BP. Even if it is stress induced or...
I observed him for 2 hours. His BP remained high. He then started vomiting and he was hospitalized. He was hospitalized thereafter and they did all the possible tests. I didn't get the feedback late what happened. But this is the first time he had a blood pressure. And all this biochemical problem. Anyway, thank you so much.
Sir, I'd just like to add one thing, just to add to on what ma'am said. Sir, I have seen patients, if the diastolic blood pressure is high, it's not reactionary.
It's not.
It is constitutional. So, you should treat this patient as a stage 2 hypertension because 100 is pretty high.
And even the first reading.
Yeah, definitely.
Even the first reading. That's the time it happens.
Increase systolic pressure by reaction of excitement or something, but diastolic blood pressure shows the resistance in the blood vessels.
So it should be, take a message to start if you see first time
I'll try to differ. Probably need to have at least 3 readings, especially at home readings.
Anyway, sir, thank you very much, both of you once again. And very nice to...
One question, Dr. Vivek. MRAs, as Dr. Sean said, are also indicated in heart failure with preserved ejection fraction. Not only SGLT2, MRAs as well.
Okay, thank you very much once again, Dr. Tulsi. And over to you.
I think the discussion